So I would like to welcome Dr. Jalal for the next state of the art present art lecture that is on molecular diagnostic tools and biomarkers for rejection in liver transplantation. So Dr. Jalal, please.
Oh, thank you for the kind introduction. Thanks the organizing committee for inviting me. I think my background is a little dark. It's early in the morning. I'll share my screen. Thank you, Sanjeev and everyone. Nice to see you all. Let me share my screen. Can you see my screen here?
Yes, sir. Hello? Yes, sir, we can see.
Okay, you can hear me, right? Okay, all right. Is the screen visible?
Yes, sir, it's visible, sir.
Okay, all right. So we're going to talk about, that's fine. So there's a very dark background here. I just need to make sure that, the slides I can see properly. All right, so the topic for discussion is molecular diagnostic tools and biomarkers for rejection or liver transplant. We go briefly about the history of immunosuppression and the challenges we're facing, and we'll review the biomarkers to optimize immunosuppression. And then we'll talk about molecular diagnostic tools in the diagnosis of rejection. So, this starts with a failure. Every big thing starts with a failure. And as you all know, we already discussed that Dr. Starzl first performed the successful liver transplant in Denver in 1967. So initially, 1963, he failed. Then he didn't give up. 1967, 11 transplants were done, actually, total 16, but the longest survival was 34 days because there had been high incidence of graft rejection. What we needed is better livers and more so better immunosuppression. So in July 67, one kid got transplanted. Post-op, patient got ALG and azathioprine and steroid. And subsequently, few more patients were transplanted. And that led to longer survival. But really didn't change until cyclosporin came in picture from soil fungus by Borel. It was approved by FDA in 1983. So this is actually not Grand Canyon. This is Texas called Palo Duro Canyon. We all know that subsequently, the next big step was tacrolimus in 1990s, followed by sirolimus. The immunological control is important. And also we know that transplanted livers rarely reject. And it has gone so successful now that in US, every 9 minutes, someone is added to the waiting list. And on average, 95 transplants take place every day. And one organ donor can save 8 lives. In US, the results are outstanding, not the best, but still very remarkable. 5-year survival exceeds 80%. And in Europe, if you see, it started low in 1980s, very poor survival. But as it progressed with the immunosuppression protocol improvement, it reached same as here. However, as we discussed earlier today, that the problems are side effects from the immunosuppression for long term. So a long way to go. What are the challenges? It's a balancing act. We have the immunosuppression related complications, problem with adherence, and the cost. We want to minimize or even withdraw immunosuppression if possible. However, if we do it early enough to do the benefits are the renal metabolic parameters, as we all know, where the maximum benefit comes with early withdrawal or reduction in immunosuppression. Also, it caused development of active rejection. So how does it happen? It has been discussed by Dr. Arora outstandingly. So we got the foreign antigen from newly transplanted organ to the APCs, resulting in activation of T cells. The activated T cells then release the interleukin-2, which binds to IL-2 receptors on the surface. In this cascade, interaction between CD2 and B7 ligand is also needed as a second signal for optimal T cell activation and IL-2 production, leads to more infiltration of graft by host T cells and damage the graft. So it's more inflammation than anything else. So we have direct pathway where the recipient T cells recognize the allogenic donor APC through donor M.I.C.E, or you have got indirect pathway where recipient APCs are phagocytosed donor APCs are phagocytosed, so donor M.I.C.Es are phagocytosed, taken up by recipient APC, and then internalized by T cells, or it's a semi-direct pathway where actually the recipient APCs acquire intact M.I.C. molecules and with the donor APCs, and then give it to the TCR activation. We all know that in presence of inflammatory cytokines or pro-inflammatory cytokines, interleukin-12 or 4, CD4 T cells become Th1 or Th2 cells and causing the damage. On the other hand, if you have TGF-beta without the pro-inflammatory cytokines, then this is conversion to Tregs, which are protected. The whole thing is balance in life, that between these pro-inflammatory cells and anti-rejection Tregs. So the challenges are, again, the current monitoring after transplant relies on clinical judgment on the measurement of the drug levels, which is very antique. No proper assessment of real suppression of the immunological system. LFTs or biopsies are either suboptimal or impractical. And obviously, we need a personalized approach. So what we can do about it? So it's the definition of a biomarker. That's the theoretical part. A characteristic that is objectively measured and evaluated as an indicator of normal biological process, pathogenic process, or pharmacological response to a therapeutic intervention. That's the definition of biomarker. But ideally, what you're looking for, something which is sensitive with a true positive rate. It identifies transplant patients who are suffering from rejection accurately, specific with true negative rate, discriminate rejection from other issues. We commonly encounter this problem. Other cause of liver dysfunction, infection, or even Hep C infection, which has been non-invasive. We can get it from saliva, peripheral blood, or other body fluids. Rapidly available. We don't want to wait for months to get it back. Inexpensive, and with a large sample size, the trial has been done prospectively. At least one independent validation has been done. So we are looking for this for the last 30 years, even more. So this was urinary neopterin, a biomarker, attempted, failed. Still relying on liver enzymes, first to figure out whether the patient is going for rejection or not. However, if you look at the sensitivity and specificity of liver enzymes, it's very low. The area under the receiver operating curve is only 0.5. Outputs are slightly better, but not outstanding. The first potential biomarker study was cytokines, because of the reason outlined before, the mechanism. So if you see here, again, I'll go through next few slides, not to test your eyesight, but just to show how many studies have been done and failed. Whenever there are too many studies, obviously you know nothing is working. So the best study actually from eosinophilia, which positive performance, but again, long way to go. So those are inflammatory markers. What about non-inflammatory markers? Alpha GST, even Dr. Negral did it, and other parameters, and really still a lot of conflicting results. So what about bile biomarkers? Well, I don't know how you collect the bile all the time they teach you, but again, it didn't work. Some patients develop ascites. They tried inflammatory marker from ascites as well. And as you see, that didn't work either. So there's a lot of gray areas. We have a lot to work. Nowadays, things have moved, the era of omics. We have genomics, which is genome-wide association studies to identify the increased susceptibility to ACR, proteomics, more importantly, transcriptomics. So transcriptomics is focusing on messenger RNA, microRNA, and long non-coding RNAs, which regulate the gene expression. And of course, we have metabolomics. This slide shows all this in a summary. The immuno has been FDA approved, but hasn't picked up in the liver world very much. And everything else still
हमारे लिए चपाती भी बना देना.
still not the best to identify. Okay, so yes. If you look at that led to a very bold approach. This is a meta-analysis and a systematic review and meta-analysis published in 2019. If you look at the 560 studies, 104 full-text articles, but only 15 qualified for assessment, and out of that, 4 went for quantitative synthesis. Again, these are the 15 studies just to show how they have been analyzed. But the conclusion is the interleukin-2 receptor expression demonstrated highest diagnostic accuracy, while the peripheral eosinophil count was only marker tested in more than one study. Still, liver biopsy remains superior to non-invasive diagnostic biomarkers, but need more studies. What about the DSAs? Are they relevant? We are learning a lot about it. So we have preformed donor-specific antibodies exposed to foreign HLAs prior to transplant. The de novo DSAs, the recipient is exposed following the transplant. And as you know that with HLA-2, that can lead to graft fibrosis and increased risk of rejection. And in steroid-resistant patients, maybe it has a value so that it can lead to diagnosis of antibody-mediated rejection. So do we have any hope, the light at the end of the tunnel? Well, possibly we do. So if you look at this cell-free DNA, immediately following transplant, allograft ischemia causes a reperfusion injury that leads to donor-derived fraction of cell-free DNA to rise. It comes down subsequently, and then when injury happens again, it starts going up. One of the important things in biomarker and transplantation is to diagnose and predict rejection and early, and so that before the graft dysfunction happens. So in the studies, this study with Jos, he touched a little bit yesterday with rejection versus perfect transplant, or rejection versus acute injury but not rejection. It's called acute dysfunction, not rejection, or acute rejection versus non-acute rejection. If you look at the AUC, with very good, it's more than 0.9. But more interestingly, the proportion of donor-derived cell-free DNA increased serially, preceding elevation of liver enzymes and clinically evident graft dysfunction, and also decreased serially following the resolution of rejection. Another study here, they used the data from clinical trial and organ transplantation cohort and did blood gene expression, both Hep C and non-Hep C patients. And what they found with the blood gene expression studies, they took 36 gene assays, which pre-identified. Again, AUC is 0.92. So we have some hope. What about the molecular diagnostic tools in the diagnosis of rejection? As you know, the current standard of care for the diagnosis, as I mentioned, is still histology, following BAMF guidelines. However, even with the expert pathologists, they have wide variation to make the diagnosis of T-cell rejection. It's low to moderate, 0.15 to 0.62 in one of the studies. So there is a lot to do, especially now when you're talking about histological diagnosis of antibody-mediated rejection, which is even more difficult to make. Now, people are recognizing that molecular analysis of liver transplant biopsies are necessary to detect rejection, to resolve ambiguities, and can assist to guide immunosuppressive regime. So this study, interliver study, this is a system they used. They used the gene profiling with the diagnosing rejection in liver transplant biopsies using microarray measurement of gene expression and machine learning. So we have relatively normal, rejection, injury, late, and also fibrosis. If you see, they're trying to see the scatter point and see whether it can detect rejection more convincing. So they came up with this diagnostic system report, which might be commercially available after validation in multi-center trials. The BAMF, the working group, realized this point. So what they're saying is that they also identified 70 gene B-hot panel that includes most pertinent genes related to rejection, tolerance, viral infection, and innate and adaptive immune responses. So that working group, they believe a pathogenesis and pathway-based molecular approach would be valuable for investigators and promote therapeutic decision-making and in clinical trials. And this is available to everybody. So data integration platform design is cloud-based. Now everything is cloud-based. And if you see the data production, histology, molecular, clinical, and the web interface, and to centralize, check, and validate the data, and then participating centers can build the analytic tools. So the take-home points are, with the advancement of next-generation sequencing technology and diagnostic assays, donor-derived cell-free DNA, mRNA, microarray profiling of differentially expressed genes, as well as characterization of cytokine responses and immunophenotypic shifts following the transplant, it may be possible in future to predict and diagnose rejection, especially early. The non-invasive biomarkers also may help in minimizing immunosuppression, individualizing care, and preventing long-term side effects. However, at present, none of the biomarkers are ready for prime time. They need validation. And also, we need to engage expert pathologists to use both histologic criteria and molecular analysis and derive an integrated classification. With that, thank you again for the opportunity. I will take questions.
जब वो स्प्रे मम्मी को इसको बोला लगाने को.
Thank you very much.
Thank you, Dr. Jalal. Dr. Akash Shukla, would you like to take on from here?
Yeah, sure. Thank you. Thank you so much. I would like to now invite, because for
We can
want
have
of
some
time.
questions also on this talk.
Yeah, sure.
Abhi she was complaining.
We can take a couple of questions, I think.
I had it handy.
I didn't find any questions in the chat box.
Yeah, Akash, just to clarify, we got 5 minutes dedicated, question answer session after each talk. And just to introduce, like Prof. Jalal is a very dear friend of mine, and at one time we have been in the same institute, and he is a very active hepatologist from US now. So I wanted actually to understand about a future step in this rejection story, because we restrict ourselves to liver biopsy and we don't know what's next. So with that intent, I think Dr. Jalal has done a great job. Prasun, just wanted to know from you, you did mention about cell-free DNA and all, which I think is an interesting thing. So what is the practical utility of these newer tools? Are we doing some ongoing studies? Is there any available data on these? Because most of studies are a couple of years back. So any current, exciting, some sort of trial going on, which you can highlight for our knowledge?
Yeah. So again, most of the trials are center specific. That's the limitation for all the biomarker studies. And that's why we need to have multi-center approach. The cell-free DNA study which I quoted actually from Levitsky's group, they have and it's published just a couple of months ago, in 2021, cell-free DNA study. And the other one, which I mentioned about gene microarray, was published last year. So again, there's a lot of movement going in the direction of microRNA, gene expression studies, and cell-free DNAs. If you look, last few years, last 5 years, I could see 5 to 10 studies came out. So, but again, it needs validation in wider setting. I think from the pathology side, that's where the BAMF working group came up. They realized that there's more work to do. As pathologists, they're not doing a great job by this classification system alone. And same way, the clinicians need to come up and work together to move forward.
Dr. Subhash Gupta has a question.
Yeah, sometimes we use surrogate markers such as EBV virus load or CMV viral load as a sort of marker for immunosuppression. So do you think certainly I read one article on EBV virus copies in the transplant period to decide on the level of immunosuppression. And certainly we use a lot of this in our unit. where we look at CMV viral, not so much for treatment, but as to know the level of immunosuppression the person is been subjected to. If the CMV counts are absent, then obviously there is sufficient immunosuppression. And if they're high, then we know they are over immunosuppressed. I just want to know what are the thoughts on this of Dr. Jalal and the other panelists on this.
So I'll say about my take on it, but obviously I'll wait to hear from other panelists. From my side, of the problem is, as you know, the CMV can mimic rejection, can induce rejection, and then it can confuse the pathologist. But yes, I mean, it may say that patient is over immunosuppressed, but we definitely don't use that surrogate marker in our setup. But I would like to hear from other people.
Dharmesh, Kaushal, are you using viral loads?
No, sir. It's actually too insensitive to be used in this setting, so we don't, unless there is a suspicion either of a CMV infection disease / in PTLDs, one would be doing the EBV loads, and in pediatric patients we do that, especially when there is a mismatch, but not to know the level of immunosuppression.
So basically what Dr. Jalal has told us is that there is a light at the end of the tunnel, but for the near short-term measures, we have to bank on histology and bank criteria only. Is that clear? Is that what the message is for the people?
Yeah, that's the message I wanted to give so far.
Okay. Thank you very much, Dr. Akash, for the next talk.
Thank you.
Thank you very much. Can I ask a quick question to Dr. Jalal, if you're still there?
Sure.
Yeah. So you did talk of Jivas. So what exactly are we looking at when we are talking of Jivas in this subgroup? So
what the people did is they're trying to identify a subset of genes which can predict rejection. So they're comparing a subset with the liver biopsy-driven rejection versus the blood is already taken. Before the rejection happens, they're still measuring it. And with the Jivas, they're trying to identify any specific genes, a set of genes, which can predict or even diagnose rejection.
Okay, thank you very much.